Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCrae.
You know, Tracy, we've all had a cough at one time or another. Hopefully not now. But for some people, the cough doesn't stop. And if it lasts for 8 weeks or longer in adults and 4 weeks or longer in children, it's called a chronic cough.
It's also a pain if
no
that happens.
kidding,
Yes.
No fun.
And it's more than just an annoyance. It can interrupt your sleep and leave you exhausted. And in severe cases, it can cause vomiting, lightheadedness, and even rib fractures.
Oh.
Hello. Here to tell us more what causes a chronic cough and what can be done about it is Mayo Clinic pulmonologist, that's a lung specialist, Dr. Kaiser Lim. Welcome to the program.
Thank you for having me.
Dr. Lim, good to have you. I guess the first question is, why do we cough?
So cough is a defensive reflex. If you think about it, we're bipeds and we're upright. So the way we handle food, it's a 90-degree turn into the esophagus. So cough has evolved for us to protect our airways. If you harken back to 150 years ago, when people die of pneumonia, they essentially drown in their own mucus. So cough is geared to clear our respiratory tract of particulate materials like food, mucus, that would be our natural defense, and noxious gases, so that our alveolar sacs, where the oxygen extraction takes place, isn't harmed.
Well, I know that sometimes a cough doesn't go away, and I would assume the most common reason is tobacco.
So a smoker's cough is always a challenge, but there's also a large segment of the public wherein after you exclude active smoking, they would still have this persistent cough. The irony is that people with smoker's cough usually don't come to our clinic because they immediately
know why
that,
they cough.
Yes.
And they know how to stop it.
So when if we take the smokers out of the equation, how often does it happen that someone has a chronic cough that they just can't get rid of?
It's common enough. One of the statistics cites something like 26 million ambulatory visits for cough. And of that percentage, a large number would be chronic cough. We have a large population of chronic cough patients. We have over 3,500 patients a year.
No kidding. And what are the common causes other than tobacco?
It's got to be allergies. I'm going to take a guess at allergies.
So part of it is, if you think about cough as the bark of a dog, and the dog is your voice box and your respiratory tract, it's signaling you that there's something irritating. So things like postnasal drip, reflux, inflammation of the airways, as well as the alveolar sac can all lead to cough.
Now, the alveolar sac are the little sacs at the end that exchange oxygen.
Yes.
With
So
the air.
there's an entity called interstitial lung disease, wherein cough may predate the diagnosis by as much as 8 months.
And you said reflux. Explain that. How does reflux cause you to cough?
So reflux is a phenomenon. Think about the burping reflex. So reflux is when abdominal stomach juices back up, and it depends on how high they get. So they could irritate the lining of the esophagus. They can also go all the way up into the pharynx or the throat area. And then you have the acid and the non-acid elements, which can cause damage to the lining of your voice box and cause irritation.
If you determine to figure out if it's a chronic cough, how is it diagnosed? Just count up on your fingers the number of days you've had a cough and then you're chronic?
So the American College of Chest Physicians and a lot of the national guidelines have established that a cough that lingers for more than 8 weeks falls into the category of chronic cough. And this is an important designation because, like right now, how do you know it's not influenza? How do you know it's not the coronavirus? The 8 weeks and the persistence beyond that tells you that it's in a different category and comes with it its own set of differential diagnoses.
Now, I assume in a non-smoker, it's important for you to determine the cause before you initiate any kind of treatment. How do you do that? How do you determine the actual cause?
So the approach, unfortunately, is a systematic elimination of possibilities. There isn't a cough meter to plug the patient in. It's a systematic elimination of possible diseases, and that's where the frustration is. So if you were in primary care, first thing you would do is to do two things. Get a chest x-ray, make sure that there's nothing going on, like cancer, like a pneumonia. Second thing is to make sure that the patient isn't taking a common antihypertensive, which is associated with up to 24% of chronic cough for those who take this medication.
ACE inhibitors?
Yes.
Okay.
Yeah. And part of the challenge is then, how do you systematically approach it? And this is where the history comes in, wherein you have to ask and inquire about disease states.
Can you have a habit of coughing?
We try not to use that term because you may not realize how much negative emotion goes into that term.
Sure.
Because people will look at somebody suffering from chronic cough and say, it's all in your head. And it discounts their suffering and the burden of disease. And it's as if the habit is something that you have acquired to get attention. And it's a totally unfair statement. So personally, in our clinic, we try not to use that term.
We talked about some of the complications, including rib fractures, but having a chronic cough can really interfere with someone's lifestyle, can it?
Oh, definitely. We looked at patient perceived burden of disease, and we were very surprised in the early 2000s when we found out how much people were suffering. So people would cough and they would have rib fractures, and rib fractures are very hard to diagnose with cough because it's not displaced. It takes 3 weeks before the callus starts to form, and that's when the chest x-ray becomes abnormal. There's actually a Mayo Clinic proceeding publication on cough-induced fractures.
Wow, pretty amazing. And that's painful.
Lasts for weeks.
Yeah, and makes it even harder to cough.
Yes.
Painful when you cough.
How do you treat a chronic cough?
So first thing you do is you go through a systematic evaluation. Do they have postnasal drip? Do they have reflux? Do they have asthma? Do they have a condition called eosinophilic bronchitis? Depending on what the chest x-ray shows, do you need a CT scan to find out whether they have sarcoidosis, bronchiectasis? We've picked up rare diseases like vasculitis, that leads to subglottic stenosis. We've also picked up things like giant cell arteritis, wherein the manifestation would just be cough, and the more prosaic, postnasal drip and reflux.
You have to be a pretty adept diagnostician to figure this out because you've named a myriad of diseases that could potentially cause a chronic cough.
That's why the cough approach is an interdisciplinary one. So I work very closely with the esophageal group. In fact, we account for almost 20% of their 24-hour impedance study. And in close collaboration with the 3 rhinologist surgeons that we have in ENT.
Nose surgeons, yeah.
Yeah. We also work with the throat specialists. There are 2 of them here at Mayo Rochester. And we also work with the allergies. I'm a board-certified allergist myself. So you have a cross-section of several subspecialties coming together to serve the patient. And we also have urogynecology, by the way.
Oh, yeah, you're going to need that because if you cough too much.
Yeah, we know what happens. So one last quick question. Cough suppressants over the counter, do they work?
They don't.
All right. That's a simple answer. Chronic cough, a cough that doesn't quit. There are multiple causes, and the cough itself can cause a variety of problems. There is treatment, but determining the underlying cause, absolutely crucial.
Our thanks to Mayo Clinic lung specialist, Dr. Kaiser Lim. Thanks for being here.
Thank you for having me.
Thanks, Dr. Lim.